welcome everyone. My name is Márk Hernádfői, and I'm a second year PhD student at the Center for Translational Medicine and pediatric resident at the Bethesda Pediatric Hospital. My main interest is pediatric oncology, and my vision is to improve survival and quality of life in pediatric oncology using and implementing scientific methods. We have two main projects, and the first is about the long-term social reintegration of childhood cancer survivors. So, can childhood survivors forget cancer after the completion of active therapy, or is it a lifelong burden that they carry? Now we are at the stage, thanks to the recent improvements in the fields of pediatric oncology, where we can cure 8 out of 10 children with cancer, resulting in 1 out of 500 adults being actually a long-term survivor of childhood cancer. But with these significant improvements arises another really important question, which is about the long-term social reintegration of these survivors. Recent research suggests that these survivors have difficulties in completing their education, finding jobs, marrying, and having children of their own. Therefore, to have the detailed answer to our question, we decided to perform a systematic review with a meta-analysis. Our clinical question was that do the former childhood cancer patients have difficulties in social reintegration compared to the populational norms, matched controls, or their siblings. And we have conducted a systematic search resulting in almost 30,000 articles, which after the selection process narrowed down to 300 eligible ones. Finally, we have altogether above 100 results. Therefore, to be able to summarize these results and the key message of our research, I would like to guide you through an imaginary course of life while presenting the results. And we start with the school desk. And before going into more detail about the results, I would like to explain the structure of our data. As you can see, it is presented on the forest plots, and we are comparing the survivors with the comparison group of populational norms or siblings. And the effect of measurement is odds ratio. And when a study or the pooled effect size takes place on the right side of the line of the null effect, it means that the investigated outcome is more common among the survivors. So we first investigated the educational attainment of the survivors. And at the level of high school, we found no significant difference. But when we have investigated further, we saw that survivors of childhood cancer are less likely to achieve the highest level of education, such as lower and higher level tertiary education. On the plot, on the bottom part of the picture, you can see that survivors of childhood cancer require almost 3 times higher odds of requiring special education needs during their studies. After finishing education, survivors must find, and everyone must find, a place in the job market, and therefore we have investigated the employment rates among survivors of childhood cancer. As you can see, we use subgroup analysis based on the survived cancer type and found significantly worse odds of being employed in case of hematological and CNS tumor survivors, and also those who received hematopoietic stem cell transplantation as part of their therapies. Our next outcome is income, which is closely related to employment. And we presented here the odds of survivors of being in the low income group compared to the middle or high income groups. And as you can see, there's a tendency in both cases for these survivors to earn less money and this difference is significant in the case of sibling comparisons. After education and employment, the next step in someone's life is family formation. Therefore, we have investigated the frequencies of marriages among survivors and compared them to population and siblings. Unfortunately, as you can see, in both cases, survivors have significantly worse chances of being married compared to their siblings and populational controls. Also, the similar results were observed when we analyzed the cancer subtypes, and the worst results of an odds ratio of 0.28 were observed in the case of central nervous tumor survivors. After marriage come the children. Therefore, we investigated parenthood among survivors of childhood cancer and compared them to siblings and populational controls. As you can see, in both cases, survivors of childhood cancer are less likely to have children of their own. After this, we have investigated the quality of life, which is measured by a variety of questionnaires. And I am presenting here some of the domains investigated by these questionnaires. But I can summarize the findings of the quality of life assessment in a way that survivors of childhood cancer usually rate their quality of life similar to the comparison groups. However, survivors of central nervous system tumors usually gave themselves worse scores, and the worst scores of all were given by the parents of the survivors, which is an interesting but documented difference in regards of quality of life. And this is about the physical health domain. Here you can see that the worst scores were given by the parents. Finally, we have investigated some health risk behaviors and mental health issues. Here I would like to highlight, however, a non-significant, but I would say clinically relevant elevated odds of suicidal ideation among the survivors of childhood cancer and the significantly higher odds of antidepressant use. So to conclude, childhood cancer survivors face several difficulties during their reintegration to society, and therefore need special attention. Of course, we have many strengths and limitations. I would say that our main strengths are about the complexity of this research and the limitations that some of these outcomes, of course, can change with time, and many of our data are based on questionnaires. And to conclude and implement our results, I would like to say that we can and we should establish in pediatric oncology care disease-specific, nationally and culturally considered complex and comprehensive protocol for a lifelong survivorship follow-up program. And the most important thing is that this reaches beyond the national competencies. Therefore, this should be performed as a systematic and WHO initiative. And if we have a survivorship program like this, then we must use it. And we have successfully submitted our article and now waiting for the hopefully positive answer. The next topic of mine is about the dinutuximab beta treatment in case of neuroblastoma patients in Hungary, which is a registry-based analysis. Neuroblastoma is the most common extracranial solid tumor in children. And as you can see on this picture, the survival is greatly defined by the staging and the grading of the tumor. And the real problem here is the very low overall survival rate of the high-risk patients. Recent years, dinutuximab beta came to rise as a therapeutical option, which is a monoclonal antibody in the treatment of neuroblastoma, which was used successfully in the last years. And therefore, we wanted to investigate its efficacy and side effects profiles and to provide real bedside data for further research. And actually, the data analysis and the preparation of article is going on right now, where I have a preliminary result of the survival, which is similar to the previously proposed ones. And I have some additional activities. I'm privileged to serve as a methodology supervisor for the first year PhD students. And I would like to close my presentation with a quote from Dylan Thomas, which states, "Do not go gently into that good night. Rage against the dying of the light." Thank you.
Thank you for this very interesting data, and may I ask you some questions? The first one was that there was a difference in the educational disabilities of hematological patients and of stem cell transplant patients compared to the others. What is the reason? Because if somebody has a cancer in the brain, I can explain it. But for these other conditions, why do they have these disabilities? What is the explanation? Maybe the success rate, maybe they were not without disease, they had some sequel from this?
Well, in many cases, the therapy is complex and it involves the traditional triad of chemotherapy, radiology, and surgery has long-term and long-lasting effects, which could influence either the cognitive functions and actually the trauma itself and the whole process of being left out of school for several years in some cases, but for at least 1 year, that can affect also the performance of this patient. And actually, I think in almost cases, there's a difference. Significant ones were only in those cases that you have mentioned, sorry. But the tendency is there in, it was employment, I think, the question you asked.
So there were disabilities, not as strong as those who were with brain cancer, but they were worse than the general.
Our general finding is that the mostly affected or disadvantaged population is the survivors of central nervous system. But in most cases, hematological malignancy survivors are also face some difficulties. And interestingly, like partially here, that when articles report on non-central nervous system tumor survivors, and sometimes in solid tumors, they are the closest to the controls, and sometimes they perform even higher.
And another question was to having children. Was there a bias, or what was it controlled for having a family? Because maybe they are socially enabled and not in a family, they are alone and they won't get children because of that.
This is why we try to investigate the complexity of the question, because usually the articles report only that if they have children or not, and a separate question if they are married or not. And so I cannot say that for example, if they're single parents or not, only the fact that they have children of their own.
Thank you for your nice presentation. My question is regarding the practice. You mentioned that we should reintegrate these children to the everyday life, but do you have any practical recommendation for this? How should we do this? So how can we change our practice based on your results?
Yes, thank you very much. I think there are many ways that this process has also started, like in different clinics using different kind of survivorship programs. Maybe there are national programs also, but we think that this should be systematical and available for all countries. And actually, this should be based on positive discrimination towards the survivors of childhood cancer. And also this should start at the very beginning, I think, with the diagnosis of the patients, and we should start involving professionals from several fields, such as psychologists and also like life coaches, kind of. And there are, for example, applications and camps that help to bring together these children, but they also need to be back together with those with who they don't share this common trauma, and then be the part of society again.
In your first project, you had a lot of data and a lot of studies. Were there any non-independency in here, and what was that, and how you handle them?
Well, we had some dependent data. I mean, there were articles reporting on separate groups, which were included in one analysis. Therefore, we needed to implement a multi-level analysis to try to solve that issue. And yes, that was me. And also, like, we were really thorough, and it was a really challenging task in this project to be able to separate and identify overlapping populations, because many times, and then this is kind of an important but smaller message of our study, that articles use great databases with thousands of cancer survivors, but if we want to follow the rules and recommendations of conducting a meta-analysis, we cannot include many studies, because, however, from 20,000 they represent data of 1,000. I cannot say with 100% clarity that this is not overlapping with some other populations.
Thank you for the presentation. I'm curious, you mentioned you have looked for quality of life data. Were you able to do analysis for each of the subdomains, or was it only for a couple of them? How many could you do?
Thank you very much. This is also a very interesting question and an interesting finding of our domain's research, because studies use a variety of questionnaires to assess the quality of life of cancer survivors. And I think there's at least 10 or 15 that we have extracted data from. And in the end, the most frequently used questionnaires were the short form 36, it's called SF36, and the PEDS-QL 4.0 or 0. And we could analyze its domains separately because we had enough data in those cases. But we tried to keep as many of our extracted data as we could. So we used standardized mean difference if the different questionnaires measure the same topic.
Congratulations, good luck with the Lancet. But sorry, the stratification of your groups in the first part with the school. I mean, it strikes me, having cancer survival, it depends whether a child just had a melanoma removed or had 3 years of chemo. So I think having cancer survivor, you have to sort of stratify them like that. That must have a great effect on what actually happened.
Yes, I totally understand. And that is why we used a subgrouping of tumor types. So we are analyzing separately the central nervous system. We identified 4 main groups: the central nervous system, solid tumor, hematological with lymphomas, and I said solid, I think that. And in these cases, many times articles presenting data only on cancer survivors as a whole population, and there's no detailed data about the cancer subtypes.
Thank you for your presentation, Márk, and thank you that I could participate in your project. It was really interesting. And I'm just asking this for curiosity because I can't remember this correctly. That could you or put you together all the patients who had hemopoietic stem cell transplantation, or you tried to differentiate between the autologous and allogenic transplantation? Because as far as we know, the allogenic transplantation has more complications because of the procedure and everything, you know, the length of aplasia, etc., than the autologous one. So could you somehow say some differences about that? That could you find something, or was just the
unfortunately, no, this is, and actually I think that this is the only analysis where we had enough data on, especially focused on those who had the hematopoietic stem cell transplantation. So it's not very well reported in regards of survivorship reintegration.
I mean, you have lots of data, a huge amount of data. So finally, you overwin, I would say, that in all of this. I mean, with public submission. In this slide and in quite a few other slides, I mean, we have a wide range of effects. So I mean, that on one side that shows that, I mean, meta-analysis is really very important, because from one single study, I mean, you can draw the conclusion to this way, to other way, to whatever way. But when there are these many studies, actually, you can really have a kind of reasonable conclusion. Having said that, I mean, that in some of the studies are actually, I mean, there are some outliers, or maybe not outliers, because this is a kind of changing level of effects. So is there anything behind this, like cultural differences, country differences, and then how can you handle this? Because, I mean, this is not only the patient, but also the society, and then how they deal with each other, and then it may, I mean, that may have a significant effect, is what is the society background?
Yes, and especially, thank you for your question. For example, in the case of marriages, I think that's really can differ in different countries and cultures. Yes, cultural and geographical differences are one. I think that should be that is to blame for the large heterogeneity. The other one, I would say, is the time period of the survivors, because in some articles we have data of patients who were diagnosed and cured in 1945. This is not the main data set of our patients, but it roots back to 1945. Most of our data or survivors were diagnosed, I would say, between 1980 and 2010 or 5, because of course we need like another 20, 30 years to be able to assess these outcomes that we are curious in. So I think, yes, cultural differences are key, and also in the time period of the diagnosis and the whole cancer treatment. Also, sometimes in studies, it varies the amount of different cancer subtypes, even if it's not detailed enough and presented in enough detail. Sometimes in studies they have a higher percentage, for example, of CNS tumor survivors, then they usually perform a little bit worse than the other groups.
Thank you for your presentation. I would like to ask something like the same, that how can you differentiate the different social backgrounds where the children came from, because it affects, I think, also the education and the employment in the future. How can you differ between them?
Of course, if there's enough data, we can do geographical subgroupings, I think. But about social background, and I think which is the smallest functioning unit is family. And very interestingly, of course, we have separate comparisons. So one is about the population-based or matched controls, and the other one is about their siblings, the survivor siblings. And I think the comparison with siblings describes well, or at least tries to describe well, the effect of the social background and the family background. And interestingly, survivors perform almost in every case worse when they are compared to siblings than to their population norms, which is really, I would say, intriguing, because siblings of survivors are also a vulnerable population, because the focus shifts towards their sick sibling. They are kind of more or less left alone, or if they're born later, then they might be overprotected. So it's not easy for even them. But there's a bigger difference between the siblings and the survivors based on our results.